It's a great pleasure to have the next speaker with us here, Dr. Patrick Renitsky, who is an assistant professor of medicine in the Division of Cardiovascular Medicine at Duke. He is also the director of the EP Fellowship Program. The topic of his presentation is atrial fibrillation ablation, current status and future direction.
Thank you, Sana. I want to thank everybody for coming. This is a great turnout. I'm going to shift gears a little bit. Dr. Hegland helped me out a little bit in introducing the topic of atrial fibrillation. I'm going to spend some time expounding on that and talk about a few other therapies for atrial fibrillation. Just a list of disclosures here. I will be talking about non-approved devices for the treatment of atrial fibrillation. Just a quick outline. I'll go over very quickly the incidence and prevalence of atrial fibrillation. I think we all know that it's very prevalent. Go over some of the mechanisms, or what we believe are the mechanisms involved in atrial fibrillation to help understand why we treat atrial fibrillation the way we do. And then I'm going to focus on catheter-based therapies for atrial fibrillation. And once I get through that, we'll talk a little bit about what's on the horizon. I'll talk a little bit about prospective trials, and then how a lot of centers are focusing their efforts in the treatment of atrial fibrillation to a multidisciplinary approach, because there's so many factors that are involved as far as anticoagulation and surgical and catheter-based approaches, and we'll talk about that briefly at the very end. So I don't think it's a mystery to anybody that atrial fibrillation is very prevalent in the United States. Currently, there's roughly 3 million people that have been identified as having atrial fibrillation. I think what we saw earlier from the video that Dr. Hegland showed with Jerry West is there's probably a lot more than that we really don't know, that don't get identified. And so the numbers are probably higher, but as our population ages, the prevalence of atrial fibrillation is going to increase to the point where by 2050 we expect over 5 million Americans to have atrial fibrillation. The incidence increases with increasing age to the point where if you take the entire population in the U.S. age 80 or older, about 9% are going to have atrial fibrillation. It is for the most part, a disease of the aging population, but as I'll talk about in just a minute, it's not exclusive to that population. So why do we treat atrial fibrillation? Well, for several reasons. We obviously want to do the best we can to prevent stroke. There's an associated stroke risk with atrial fibrillation. In addition, we want to prevent tachycardia-mediated cardiomyopathies for patients that have poor rate control. As far as I'm concerned, for my talk, we also want to try to improve symptoms and improve quality of life. We can do this by either controlling the rate in many instances, or restoring sinus rhythm and controlling the rhythm. And we'll talk a little bit about why we do that and how. Now, Dr. Hegland talked a lot about pharmacologic therapy for atrial fibrillation, and there's been a lot of data to support rate control versus rhythm control. A lot of good data, and here I've cited the AFFIRM trial, which did just that, compared rate control to rhythm control in patients with atrial fibrillation, and the rhythm control arm used antiarrhythmic drug therapy. But there's a few things that I think that we need to take from this study. As it turns out, the results were pretty much a wash, if not a little bit more benefit in the rate control strategy. That probably is related to the pro-arrhythmic effects of a lot of the antiarrhythmic drugs we use. Now, AFFIRM was done prior to the release of dronedarone, so that you have to take that in consideration as well, because we have seen that there has been a mortality benefit for dronedarone, and the results may have been a little bit different, probably not too much different, had that antiarrhythmic drug been used in this trial. But I've highlighted 2 points that I think that we need to take away from the AFFIRM trial. One is that warfarin use has been associated with a decreased mortality in these patients and maintenance of sinus rhythm. So you might say, well, you just told me that antiarrhythmic drugs are proarrhythmic and they have an increased risk of complications and mortality. Well, sinus rhythm doesn't necessarily always have to be obtained with antiarrhythmic drugs. But from this study, what we do know that it probably does behoove patients to maintain sinus rhythm as long as we don't do something that offsets that benefit with some kind of adverse effect. So what are the mechanisms of atrial fibrillation? I think we just think it's just a bunch of chaotic junk going on in the heart, and we don't understand it very well. And honestly, that's to a large extent that's true. But I think we've begun to focus a little bit on what we think causes atrial fibrillation, what sustains atrial fibrillation, and it's helped guide us in how to treat atrial fibrillation. One thing that's definitely been determined is that the pulmonary veins seem to be focus or foci for AFib triggers. We'll talk a little bit about why that's the case in a minute. There are certain areas of the heart that perpetuate the atrial fibrillation that we've been able to identify with things like optical mapping that I obviously won't get into. And then another thing we know is that there's a critical mass that is necessary to sustain fibrillatory conduction. Well, what do I mean by that? Well, mice really don't get AFib. There's not a lot of surface area in their heart for these fibrillatory waves to conduct over, and they end up colliding with each other, and the atrial fibrillation terminates. This is one of the reasons why patients with heart failure tend to get atrial fibrillation. As the chambers begin to dilate, there's more surface area for these erratic impulses to propagate over, and they can sustain themselves. This is one of the reasons why heart failure patients, anywhere from 40, depending on what data you look at, anywhere from about 40 to 60% of the heart failure population may have concomitant atrial fibrillation. And one of the other things that plays a very critical role in atrial fibrillation is the autonomic nervous system and its interplay with in the heart, and I'll talk about that as well. So I'll start by citing some work that was done in Bordeaux, France by a gentleman named Michel Hasseguer, whose long-time interest has been in the mechanism of atrial fibrillation. And he and his group in the mid-90s took patients with normal hearts and atrial fibrillation who had these paroxysms of atrial fibrillation to see if they could map out where the triggers that were firing that caused atrial fibrillation were coming from. And as it turns out, the vast majority of these patients had their triggers originate in the pulmonary veins. And it seemed that the left-sided pulmonary veins had an even higher incidence than the right-sided pulmonary veins. There were some other areas outside of the pulmonary veins, in the right atrium over here on the area of the heart called the crista terminalis, that were also sites for triggers for atrial fibrillation, and also, not in this study, but in other studies, the area of the coronary sinus has been implicated as a site for triggers for atrial fibrillation. Well, why might that be the case? Well, if you look at histologic sampling of the pulmonary veins, you find that there isn't really a discrete endpoint of venous tissue where it enters cardiac tissue. There's these fronds of myocardial tissue that extend into the pulmonary veins. And these fronds seem to be the areas where the triggers occur. But it's not that simple. It's not just the fact that there's myocardial tissue there. It clearly has to be different than the other myocardial tissue. Otherwise, the triggers for atrial fibrillation would occur anywhere in the heart. But for some reason, they seem to be localized to these particular areas. Well, as it turns out, there are fat pads around the pulmonary veins. It's very difficult to see from this diagram, but there's some black stars. This is right above the left superior pulmonary vein. There's one here just septal to the right superior pulmonary vein, and there's one right here at the os of the coronary sinus. And what these fat pads correlate with is autonomic ganglia. These are the areas of the heart that receive the highest concentration of autonomic intervention. Well, how does the autonomic nervous system affect the heart? Well, the two branches of the autonomic nervous system have very different effects. The parasympathetic system or vagal stimulation causes what we call a shortening and refractoriness in the atrial and pulmonary vein tissue. Well, what do we mean by that? Well, that means that tissue is much more susceptible to firing at faster intervals than if there's sympathetic output. So it allows it to recover much faster when there's the parasympathetic input is delivered. Whereas the sympathetic stimulation results in calcium loading and triggered activity, so PACs, things like that. So it's knowing this, it's not surprising to know that endurance athletes tend to get atrial fibrillation at a pretty high incidence. And probably the reason for that is because they have very large swings in autonomic tone. For example, if you check the pulse of a marathoner, they may have a resting heart rate in the 40s, and that's typical for them. But then when they're out training, they have very high sympathetic outpourings to get their heart rate up and meet their metabolic demand when they're training. As it turns out, when these people have atrial fibrillation, they typically get it either shortly after they initiate their exercise or about 30 minutes after they finish their exercise. And it seems to be pretty consistent. Now, that's not always true, but if you ask these people, when it occurs, and you mention this to them, they're like, yeah, that does seem to correlate. And it's probably because those periods of time are where you have crossings of these two branches of the autonomic nervous system, where you get shortening of refractoriness and triggered activity at the same time, leading to these paroxysms of atrial fibrillation. Well, now that we know a little bit about what might cause it, we need to know a little bit about what we got to do to treat it. Dr. Hegland talked a little bit about antiarrhythmic drugs, and even to date, for patients with refractory symptomatic atrial fibrillation, antiarrhythmic drugs are considered the first-line therapy. It depends a little bit on what the concomitant medical conditions are that are associated with the atrial fibrillation. For example, as Dr. Hegland mentioned before, the patients with structurally normal hearts, no renal disease, no heart failure, no hypertension, they really can choose just about anything. But typically the first-line therapy are a class 1C agent, either flecainide or propafenone. You can consider sotalol. However, in this healthy population that's usually very active, sotalol oftentimes is not well tolerated because of the beta-blocking properties of the medication. And oftentimes they have low resting heart rates, and sotalol can even worsen that bradycardia. If sotalol fails, then we can oftentimes consider other agents like amiodarone or dofetilide, which both have shown a little bit more efficacy than the aforementioned three antiarrhythmics, or even consider catheter ablation. With hypertension or with LVH, there was some talk about ventricular wall thickness and when to use what antiarrhythmic. We tend to avoid class 1C agents for sure in this population. Sotalol is still used not that infrequently in this population, but it depends on the degree of hypertrophy. But more often than not, we'll default to amiodarone as the first-line therapy. I haven't included dronedarone in this schematic. It wasn't included in this schematic because these guidelines were created and prior to the release of dronedarone, and the ACC, AHA, ESC really hasn't decided for sure on where they're going to place dronedarone in this algorithm. But I'm not going to go into too much more detail about this, but the one thing that I do want you to notice is that at the end of every single one of these arrows is a little green box that says catheter ablation, which is essentially the last resort or the final therapy for treatment in refractory patients. Well, let's talk a little bit about antiarrhythmic drugs. We tend to use them as a first-line therapy, but I think it's very important to understand that there is a price to pay with antiarrhythmic drugs. And we know from many, many studies, this was done from a meta-analysis by Greg Flaker to show that these drugs do carry with them an associated mortality, in all likelihood related to proarrhythmia. Well, it's not just the increased mortality associated with the drugs, but honestly, the drugs really don't work that well. If you look at the Canadian trial for atrial fibrillation, which looked at amiodarone and compared it to propafenone and sotalol, at 2 years of follow-up, this was one of the best studies for amiodarone in the treatment of atrial fibrillation. It showed that amiodarone had an efficacy of about 60%. So 60% of these patients remained symptomatically AFib-free at 2 years of follow-up, whereas sotalol and propafenone were very similar. They were right between 35 and 40%. But if you take some of these larger trials and look at the efficacy of these antiarrhythmic drugs, they really tend to hover right around that 40% range, which is where I think we can probably say that's probably where we get most of our efficacy. Amiodarone and dofetilide, a little bit better. The class 1C agent sotalol, certainly right around 40%. And if less than half of the patients we're treating are actually staying free from atrial fibrillation, I'm not sure that we can really consider that very effective therapy. The other thing about antiarrhythmic medications is their potential side effects. This guy did not have his face spray painted. This is actually amiodarone skin toxicity. A lot of times these patients in the past were called the Smurfs because they turned blue, and this is something that we have to deal with in treating patients with antiarrhythmics on a long-term basis. Well, now I'd like to segue into catheter-based treatments. We know that from a pharmacological standpoint, we have those therapies available. They are considered first-line therapy, but when those antiarrhythmics fail or when they're not tolerated, then catheter ablation is typically what we go to. So I mentioned before that usually the triggers for atrial fibrillation involve the pulmonary veins. So how do we locate that and how do we determine that? Well, again, the gentleman I mentioned earlier, Michel Hasseguer, designed what's called a Lasso catheter to record signals in the pulmonary vein and to allow us to determine which pulmonary veins were firing during atrial fibrillation. This is a cartoon depicting what that catheter might look like. The catheters are usually delivered through the venous system. They go into the right atrium through the inferior vena cava, and then we actually have to go through the septum of the heart to the left side via a needle approach to put these catheters in the left side. Obviously, the patients are anticoagulated during this procedure to prevent thrombus formation and stroke. Well, this is an example of recordings we might see from that catheter, and you will not be tested on this, so don't worry about this. But the concept, or the thing that I want you to take away from this is all these little blips represent electrical recordings from these various catheters. And if you'll notice here, there's an abrupt termination of blips on this Lasso catheter when we're delivering a burn, but the patient sustained sinus rhythm. So essentially what's happened here is this vein has been electrically isolated from the rest of the heart. This is the goal, or the main goal we're trying to achieve when we do a catheter-based approach for treatment of paroxysmal atrial fibrillation. This is an example, it's a little bit harder to see because of the white background, of a patient who's in sinus rhythm, who's had their veins isolated, and we've delivered high doses of isoproterenol to see if we can get them back into atrial fibrillation. And what's happened here on this Lasso catheter is the pulmonary vein fibrillates, but the heart maintains sinus rhythm. This is what we're trying to achieve when we do this procedure. If you can eliminate that trigger and dissociate that trigger from the rest of the heart, theoretically you can eliminate that patient's atrial fibrillation. Well, I put this in here to remind me that despite the fact that these may seem like big and easy targets, sometimes they're difficult to find, and things tend to hide from us on occasion. So this is an example of three-dimensional maps that we might generate when we do this procedure. We obviously need to know where the veins are, we need to know how many there are, and we need to know the caliber of those veins so we know where the junction of the vein and the atrium is. If we go too far in the vein and deliver these burns, we can actually stenose these veins off, and by staying out of the vein, we prevent that pulmonary vein stenosis. These maps are generated via a GPS-type system. We have a catheter that moves around the atrium, takes a point in space, memorizes that point. We move the catheter to another point. It takes all these points together and generates this three-dimensional structure based on three magnets that are sitting under the patient's body, using that catheter as a reference. Well, the next phase of technology development was actually being able to import either a CT or MRI image into our computer as we're generating that map, so we can see how good of a job we did, see if we missed something. And this is an example of bringing in the left atrium with the pulmonary veins and even the esophagus into our map to make sure that we identified all the veins, where they were, how they took off, where the branches were. So it helps us in not only safety but also in efficacy. Well, one thing we weren't able to do for some time is be able to see what was going on in the heart in real time while we were doing it. All we had was a two-dimensional fluoroscopic view. Well, then intracardiac echocardiography got evolved, and we could put a catheter into the heart and see in real time where our catheter was and its proximity to various structures. Here, this echo-dense line here represents a temperature probe that's in the esophagus, and this echolucent structure represents the esophagus itself. This is the catheter tip, and this green light represents the catheter tip's contact with the wall, and you'll see the pulmonary vein come into the picture right about now. There it is. These are the pulmonary veins there. So we can use this to guide us in real time to make sure we're not going too deep into the vein and making sure our catheter is in contact. Well, one of the things on the forefront is actually using 2D echo but making it 3D. This is an example of a case that was done at Duke where a three-dimensional echo probe was put down, and in this picture you can actually see the mitral valve opening and closing in real time. You can see the left atrial appendage right here in the left superior pulmonary vein. This is the ridge between the appendage and the pulmonary vein where a structure called the ligament of Marshall runs through, which is a very common trigger for atrial fibrillation. And this line represents the catheter. So these imaging modalities are getting better and better in allowing us to be able to see exactly what we're doing when we do these procedures.
Could you please comment on whether these imaging modalities have been shown to improve patient outcomes?
Yeah, so as it turns out, that's a very, very good question, because these do not come without a cost. Intracardiac echocardiography and some of these mapping systems do not come without a cost. As it turns out, there have been small studies, single-site or dual-site studies, that have looked at if there's a benefit to these, but unfortunately there haven't been large randomized trials to determine whether not only are they safe and effective, but are they cost-effective, which is probably the bigger question. I think we feel better knowing that we can see this in real time, but no, the answer to that question is there haven't been large randomized trials to determine whether these modalities improve outcomes. So this is just a video sort of putting a lot of this stuff together. What's been done here is we've generated this three-dimensional map by outlining echo-based contours of the heart. This is the left atrial chamber and the pulmonary vein, and you can see this cut through our map. We generated this in real time. So rather than using a MR or CT picture that was generated a week ago, this structure was generated during the procedure, okay? And we can use this in real time to help us navigate through the atrium. More technology allowing us to reproduce these ultrasound-guided images, MR images, and catheter-based images to help guide us. Well, the one thing, there was a very good question mentioned in the last session about using things that are FDA approved for certain indications and not for other indications. Until very recently, when we did catheter ablation for atrial fibrillation, every catheter we used was off-label for that indication. Until this recent Thermocool study was done, where an irrigated tip radiofrequency catheter was studied and approved by the FDA for the indication for treatment of paroxysmal atrial fibrillation. This is the only catheter that is FDA approved for this indication, and it is, again, paroxysmal atrial fibrillation. The primary study was just to look at the chronic effectiveness and safety of the catheter with a 9-month follow-up window. The inclusion criteria, again, were patients with paroxysmal atrial fibrillation. They had to have had at least 3 episodes in the last 6 months, one of which was well documented either by monitoring or by an EKG. They had to have failed at least one antiarrhythmic drug, either class 1 or class 3, or beta blocker or calcium channel blocker, which were considered antiarrhythmics for this study. 18 years of age and older and consentable. And as it turns out, when compared to antiarrhythmic drug, the patients that were treated with the catheter achieved much more success at freedom from atrial fibrillation, which was freedom from symptomatic atrial fibrillation, which was the primary endpoint for the study. Now, so what can we expect from a patient with paroxysmal atrial fibrillation undergoing a single catheter procedure? Well, there's a lot of data from many centers that do high volume, but very little data that is from large randomized studies on catheter ablation. These are some of the larger studies and some of the more cited studies. And as you can see, the majority of these patients did not have structural heart disease. They had true paroxysmal atrial fibrillation. Here, these indicates whether these trials were done with these 3-dimensional navigation systems or with fluoroscopy alone, or ICE referring to intracardiac echo. And these were the success rates for these various centers at freedom from atrial fibrillation. Again, this is symptomatic atrial fibrillation off of drugs. So the thing that you need to know about these studies is that, number one, the follow-up periods for these studies were relatively short, okay? And this was freedom from symptomatic atrial fibrillation. That's not to say that some of these patients had episodes of atrial fibrillation which were not symptomatic, but that were occurring after the procedure. In reality, for this population of paroxysmal patients, at 2 years of follow-up, we typically expect about 65% freedom from atrial fibrillation with a single procedure off drug. Well, the next thing I want to focus on is the clinical trials. There have been multiple trials that to address the question of rhythm control versus rate control. But again, in many of those trials, and almost all of them, the rhythm control arm has been with antiarrhythmic therapy as opposed to catheter-based therapy for that treatment. The RAAFT trial, which was completed about 2 years ago, the pilot study, and the follow-up study was just completed a couple of months ago, was a prospective randomized multi-center study looking at patients with paroxysmal atrial fibrillation, comparing catheter-based therapies to antiarrhythmic-based drugs. The pilot study showed that the overall recurrence of symptomatic atrial fibrillation was 13% in the catheter-based treatment group and 63% in the antiarrhythmic-based group. The 13% recurrence is a little better than what we've seen in other trials, but certainly the 63% recurrence in the antiarrhythmic group is pretty much on par with what we would expect. The CABANA studies...
Could you please comment on what studies were used to look for atrial fibrillation, or did they just look for symptomatic AFib and gauge it based on the patient's symptoms, or did they also look for asymptomatic AFib by doing Holters or some other?
So they did do Holter monitoring on these patients, but the difficulty with that is that you only get a brief snapshot in time. And these patients, again, were paroxysmal. So if you don't happen to monitor them during that period of time where they're having their paroxysmal episode, you obviously may miss quite a bit of atrial fibrillation. So this definitely isn't a perfect science when it comes to follow-up, unless you do implantable recorders or if they have a pacemaker in place where there's continuous recording going on. And the problem with doing long-term recording, like loop recorders, is patient compliance. A lot of times patients won't comply with wearing a monitor for 2-4 weeks at a time to try to truly answer that question. Now, the the CABANA study is a multi-center study that's being run through the Duke Clinical Research Institute, and this study is currently enrolling now, and it's targeting greater than 3,000 patients at over 200 centers. And the idea is to compare catheter ablation to best medical therapy, either rate or rhythm control. This involves patients that are at high risk for complications related to atrial fibrillation. The reason for that is because otherwise it would take 20 years and 10,000 patients to actually be able to determine whether there is either a mortality or true morbidity benefit to this. So the target is patients that are either older, who have a higher stroke risk, or younger with stroke risk factors, high blood pressure, diabetes, etc. The endpoints, the primary endpoint is all-cause mortality, and secondary endpoints that are being evaluated are stroke, burden of atrial fibrillation, quality of life, cost and cost effectiveness, cardiovascular related death, and then composite endpoints of these. Now, I put this in there. This is a snapshot I took of Dr. Hegland after a long AFib ablation. And the thing that about these procedures is that they tend to be long, and we tend to battle atrial fibrillation for many hours sometimes, and we feel defeated at the end of the day sometimes after these long days, as you can see from Dr. Hegland here. So there are other devices that have been in development and are currently being studied to try to make this easier, safer, and potentially more effective. Now, a lot of the things on this slide here are no longer in production due to problems and lack of funding. But I just put these all on here so you can get an idea of the fact that there's a lot of people that think that balloon therapy may be the next thing for treating paroxysmal atrial fibrillation. Well, what do I mean by that? Well, taking a balloon, putting it into the pulmonary vein, or at the os of the pulmonary vein, delivering some sort of energy, cryo energy, laser energy, microwave, high-intensity focused ultrasound, some kind of energy to electrically isolate that vein and do it much more quickly. Well, these are some of the tools that are in development now. The cardiofocused laser balloon is a balloon that delivers laser energy, and you can direct where the laser is delivered around the vein. It's not circumferential, but you can deliver it in little pieces around the vein, and you can visualize this endoscopically and see where these lesions are being delivered. This is currently in studies right now. We should have the outcomes from this soon. The cryo balloon is completed. The STOP AF study was done to look at the efficacy of the cryo balloon in treating patients with paroxysmal atrial fibrillation. This balloon, initially when the study was done in the pilot study, they had a little bit of difficulty achieving complete isolation, and they had early recurrence. They subsequently did a follow-up study with two lesion deliveries and found they had good efficacy. This is in the FDA right now for approval, and then the high-intensity focused ultrasound balloon has had some difficulty and they've stopped studies right now. Other types of catheters that deliver lines of ablation have been used as well. This is the Ablation Frontiers device that delivers various types of lesions around the heart. The Takata study uses a catheter that uses force sensing on the tip of the catheter to determine whether the catheter is in contact. If the catheter is not in contact with the heart, it's not going to deliver a lesion. These are some of the newer tools that are being studied right now. We have magnetic navigation, where we can let magnets drive the catheter rather than the operator being exposed to the fluoro during the procedure. It allows for very precise manipulation of the catheter and very atraumatic manipulation. We also have other types of robots that allow us to give very precise movements to the catheter and give very stable lesions. But the last thing that I'll mention is something called the CyberKnife. There's Wynne Davies in London has actually been investigating this in a pig model to see if we can do completely non-invasive ablation when we do these procedures. The issue has been that you really don't know the result for about a week after you deliver the lesion. What they've done is they've used the CyberKnife to knock out the AV node in a bunch of pigs, and it's been very, very effective, but the problem is they don't know the result for about a week afterward. So this is something that may be on the forefront of what we do in ablation to eliminate putting catheters in the heart at all. I mentioned that I would talk a little bit about atrial fibrillation centers of excellence, and these are evolving or rising up all over the country because of the fact that it requires a multidisciplinary approach to treat this condition. It involves hematologists to regulate anticoagulants, primary care physicians to keep everything together, surgeons for patients that have mitral valve disease and concomitant atrial fibrillation, electrophysiologists, cardiologists, etc. And these centers are designed to take this multidisciplinary approach to treat the patient as a whole and give the best care and best outcomes for these patients. And just a few closing thoughts. My wife loves this slide, so I had to mention this. She told me we couldn't afford beer anymore and I'd have to quit. And then I caught her spending $65 on makeup. I asked her how come I had to give up stuff, and she didn't. She said she needed the makeup to look pretty for me. I told her that's what the beer was for. I don't think she's coming back. And I'll take any questions.